Welcome again to Empowering Choices, Value-Driven Advanced Healthcare Planning. I am your facilitator. We have the lovely presenters Brian Goldberg and Pamela Edgar, who are going to take you through this important, informative work. And so Pam, she is our Director of Education. She is a licensed creative arts therapist with an MA in drama therapy from New York University. She has over 15 years of experience with older adults and families in nursing homes, daycare programs, nonprofits, telehealth organizations. Pam is also a trained end of life doula and creates pottery in her spare time. And great to have you doing this today. And then we have Brian. Brian Goldberg is currently an emergency medicine resident. Prior to matriculating in medical school, he gained over 15 years of experience in emergency medical services, serving as an EMT, paramedic, educator, and departmental manager across New York City, Nassau County, and Chicago. So welcome you both. Thank you for doing this today, and let's get started.
Great. Thank you so much, Rochelle. And thank you all for being here with us today. We're really excited to be presenting for you. We do have quite a bit of material. So we are going to talk about why advanced care planning is important for families impacted by dementia, just a few statistics and some level setting information to get us started today. We'll talk a little bit about the benefits of planning ahead. We're going to talk about this idea of value-driven advanced care planning, and really starting with conversations and what it means to base your healthcare decisions in your values. So we're going to talk about that a little bit today. And then we're going to go into the more sort of information, more practical information about the documentation, talking about advanced directives, healthcare proxies, living wills, medical orders, what they are, what the differences are. And then Brian is here to really share the paramedic's perspective. You know, what happens in an emergency situation when 911 is called, and what can you do to be prepared for that? And then we'll have some references and resources for you as well. So it's going to be a packed hour and 15 minutes, but we're really excited to be sharing this with you. So as we start here, again, just some statistics. This is the 2025 Alzheimer's disease facts and figures from the Alzheimer's Association. And you can see here over 7 million people, 7 million Americans are currently living with Alzheimer's disease. And that's about 55 million worldwide. That's expected to triple in the next 25 years. It'll be about 153 million by 2050. So this impacts about 1 in 3 families, and it's just so important to recognize, you know, how people are impacted in the importance of planning ahead. A few more statistics. Statistics show that less than 50% of adults 65 and over have completed advanced care planning documents. And we know statistically that more than 80% of adults diagnosed with dementia will need someone to make decisions for them at some point in time. And of course, as people get into the later stages of dementia, that number increases. Right? So we're so glad you're here today, and we hope that this will help you in your advanced care planning process. When we talk about values and preferences, another interesting statistic is we know that approximately 70% of Americans state that they would prefer to die at home rather than in a facility. But we know that approximately 31% end up dying at home, and over 60% do die in a facility. So this is another reason why that planning is so important, and understanding what your values are, planning ahead financially, doing healthcare planning. Our talk today is going to be primarily focused on the healthcare planning piece. And as Rochelle mentioned earlier, we do have legal and financial planning and Medicaid planning webinars every month. So you can look on our calendar for those if those are also of interest to you. So the benefits of planning ahead. Right? There are many reasons why engaging in a healthcare planning and advanced care planning process can be helpful, right? And first and foremost, understanding your health conditions. For those with dementia, being able to understand what to expect going forward with the progression of the disease, right? What the different stages look like and what you can expect. As Rochelle also mentioned, at CaringKind, we have a Dementia 101 series that talks about signs and symptoms and the stages and adjusting for care partners. That can be really helpful for learning more about this. But planning ahead, talking to your doctors, understanding what this journey might look like for you and your family can be so helpful and empower you to make those decisions. Discussing values, preferences, and wishes, right? While you have the time to do so, while you can really think about what those are for you, can really give your caregivers and decision makers so much more peace of mind knowing that they're making decisions that you would make for yourself, right? And if you're a care partner, having those discussions or understanding, who is this person, even if they can't share their wishes anymore, really thinking about, who they are, how have they lived their life, what's important to them, that can guide your decision-making process as well. Planning ahead allows for greater control. It reduces stress and family conflict, right? So it allows everyone to get on the same page. It minimizes complicated and complex grieving, right? So, of course, having a condition like Alzheimer's disease and other dementias brings a lot of loss and grief along the way. And of course, when the person passes, there's always sadness. But advanced care planning can minimize some of those complicated things like guilt or regret or not knowing what someone would want and feeling uncertain about decisions that have been made. It can also reduce unwanted hospitalizations and treatments, right? By knowing this is what someone does want, this is not what they want. You can reduce unwanted treatments and improve end-of-life care. And so now we're going to talk a little bit about starting with conversations. And after this section, we'll pause if there are any questions on where we are so far. So why start with conversations, right? And this is going along the lines of what we just talked about in terms of the benefits. But it really allows you to discuss conditions with doctors. A lot of people think about the advanced care planning process as the documentation, right? I've got to fill out the documentation, cross off the checklist, and then I'm done. We hope that you walk away today with a different idea of advanced care planning as a process that continues over time, right? So you can discuss conditions with doctors as things change, stay in those conversations, define your values and preferences. We're going to talk a little bit more about that in a minute. Share your why with your loved ones and your doctors. The decisions themselves are important, right? Like, do you want resuscitation or not? Do you want help with breathing in terms of ventilation or not, right? But what's even more important and beneficial for your decision makers to know is why. Why is that your choice? If you want resuscitation, why do you want it? Under what conditions would you want it? Under what conditions may you not want it? right? If you want a ventilator, is that indefinitely? Would you want that forever? Or would you want that for a certain amount of time? Right? So it allows you to really share the reason behind your choices. Conversations also allow you to discuss roles. Who is the main decision maker in the family, right? Who is going to be the person to make the decisions, to follow through with the wishes? And what other roles might there be in the family, right? Do you want other family members to help support those decisions? Um, is is someone going to, primarily be the caregiver and other people support by doing meal prep or buying groceries, right? It allows you to really talk about the roles. And if there are people in your family who you would not want involved in decisions, you can make that known as well, right? Because, some people have chosen family that are friends that they would rather be their decision makers, right? So it allows you to kind of lay that out, allows you to hear different perspectives for things, ensure understanding, get on the same page, right? So if you're asking someone to be your decision maker and they have questions or concerns, you can talk it through with them, see if they are the right choice or not, or maybe there's someone else that you would consider. So starting with conversations is so beneficial. We have some great conversation starters here. And again, we'll share a PDF of these slides so you can have this, but it allows you, about me, being able to blank is the most important thing to me because, right? So it allows you to think about what is important to you and why. It also allows you to think about, have you seen end of life situations play out with other people? And what did you learn from those situations? I was thinking about what happened to so and so, and it made me realize this is what I want for myself or not want for myself. It allows you to think about your culture, right? What a good day looks like for you, what quality of life looks like for you. And we're going to talk about that more in a moment, right? I would not want these kinds of treatments if there's a little chance of recovery because, again, getting to that why, getting to understand the reasons behind things, which takes us to defining values. Right? A lot of people will use terminology and say, I want to be sure that I'm treated with dignity and respect, or I want a good quality of life. Well, what does that look like for you? Right? Because what quality of life looks like for you and what it looks like for me could be very different things, right? So defining that, not taking for granted that we know what these words mean. And if you're a caregiver and you hear someone say, well, I just want a good quality of life, great, stay there. Yeah, tell me more about what that looks like for you. Or you can say, from what I know about you, it seems like quality of life means listening to music and eating ice cream and being able to, talk with your family. Is that right? Am I getting that right? Are there other things that are important? What does that look like for each person? Again, independence, privacy, right? And so, especially a value like independence, we know that independence is going to change over time. When someone has Alzheimer's or another form of dementia, independence is going to look different. There is a time that's going to come when they're going to need more help with care needs, but there can still be a spirit of independence, right? And so what would that look like as your condition changes? How do you think about that? For some people, it may be, I want to choose the clothes that I get to wear, or I want to make sure for dignity, I want to be sure my hair is done a certain way. That helps me feel beautiful and dignified. Or I had one client who wanted her red lipstick every day, needed her bright red lipstick on, and that was her dignity and how she presented herself, right? Again, other choices like pain management, care wishes, location of care, right? These are all values and choices just to think about. Okay, we're going to move into the documentation section, but I'm going to see if anybody has questions to this point. I am not seeing any, so I'm going to continue on. And again, please feel free to put questions in the chat at any time. So now we're going to move into the documentation and really looking at what is the process for capturing your values and wishes and naming who will make decisions for you, right? So we have here an advance directive. An advance directive is an umbrella term. It's legal documents that allow you to make the decisions about your healthcare. You can choose a trusted healthcare agent, determine the healthcare decisions, again, based on your values and preferences, and make those end-of-life decisions as well. So there are kind of two components to an advance directive, and a lot of times you'll hear these documents used interchangeably. So I know it can be confusing. So we want to kind of help you understand the advance directives is a comprehensive document that allows you to choose both a healthcare proxy and a living will, right? So the who is the healthcare proxy or healthcare agent. You appoint someone to be your decision maker. And a living will is the written instructions or statement of healthcare wishes. So we're going to talk now a little bit more about the healthcare proxies. So the healthcare agent is, again, the person appointed to make medical decisions for when someone is no longer able to make them for themselves. So a healthcare agent only acts when someone no longer has the capacity to make medical decisions. So if you name someone as your healthcare proxy and you are still able to make decisions for yourself, they can't make decisions for you until you are no longer able to make them for yourself, or you decide, or a person decides, you know, I want this person to start making decisions for me. You do not need an attorney to choose a healthcare agent. You can use a healthcare proxy form in order to do that. And we have the information here for the New York State Healthcare Proxy. And this will be included in the slides that we'll share with you. So how do you choose a healthcare proxy? You can choose in New York State, you can choose a healthcare proxy and backup proxies. So you're not able to choose a group of people, right? Because that becomes very complicated. You can decide, you know, I want all my children to be involved in the healthcare planning process, but you know, my older daughter is going to be the sort of the main spokesperson, right? And then you can choose a primary and backups. You would want to choose someone that you trust with your life, someone that is available for you, someone who's a good advocate. Because sometimes the healthcare proxy is going to have to talk with the doctors, ask questions, advocate for your wishes. Someone who is of legal age, is willing to manage conflicts that might arise, right? And is able to separate their views from your wishes. That's really important. Someone who, you know, they may want different things for themselves, but they understand what you want and are able to act according to your wishes. and desires. People not to choose a healthcare provider or the owner of the healthcare facility. So your doctor who is currently treating you is not able to be a healthcare proxy. If you have a family friend who's a doctor who's not your doctor, that's okay, but it can't be someone who's treating you, your court appointed guardian or conservator, or anyone with a conflict of interest. And what decisions can the healthcare agent make? They can make most medical decisions that you can make for yourself, right? So they can authorize a doctor to operate on you. They can make decisions to decline or stop treatments. They can make decisions to start treatments. The one thing, this is a nuance of New York State, and every state is a little bit different, but one nuance of New York State is that healthcare agents cannot make decisions about nutrition and hydration unless you have specific written instructions for them to do so. So you can write that in your living will. You can write that you want your healthcare agent to be able to make decisions about nutrition and hydration on your behalf. You can state what those wishes are, but you do need to specify that in the living will. So nutrition and hydration needs to be specified, specific written instructions for nutrition and hydration to be stopped. And again, that's a New York State nuance. Another New York State nuance that we want people to be aware of is the New York Family Healthcare Decisions Act. This was enacted in New York State in 2010, and it's used when no healthcare proxy is appointed and a person becomes incapacitated and unable to make decisions for themselves. And so basically the idea behind this was, the government decided that it's better for families or people that, that know a person to be involved in the decision-making process rather than doctors just making decisions for someone without consultation or without, support and knowledge from someone who knows the person. So it provides a hierarchy of decision makers, starting with the court appointed guardian, spouse or domestic partner, adult child in birth order, parent, adult sibling, and close friend. So this can be a helpful thing if someone, is in an emergency situation and doesn't have a chance to appoint someone, that, they would reach out to someone close to the person. It also can mean that someone that you don't want involved in your decision-making process could be, if you don't name a healthcare proxy, could be invited in to make decisions. And that has certainly happened with people who are separated. They're not officially divorced, so that it's still legally, it's a spouse. They would be asked to make, be involved in the decision-making process. So this can be complicated. We want you to know about it. It's another reason why it's really beneficial to name the healthcare proxy that you want to make decisions on your behalf. Okay, we're going to go into living wills now. And again, I'm just going to pause for a moment and see if we have any questions. Anything on anyone's mind in the chat? Okay, not seeing any, so I'm going to continue forward. Okay, so now talking about the documentation and living wills. The living will is the instruction document, right? So if you think about it, the healthcare agent is the spokesperson, the who, and the living will is sort of the evidence or their guide, their script, their guide, right? So you have the who and the what. The living will is the written instructions that the healthcare agent can use to be their touchstone or their blueprint for how they advocate and the types of decisions that are made. Again, it's used when someone has become incapacitated and unable to communicate or make decisions for themselves. And it really focuses on life-sustaining treatment and interventions, right? So the living wills are very often focused on these kinds of treatments, right? And again, that's why we encourage the conversations, because the living will documents don't all get into how someone wants to be cared for, or what the quality of life looks like. You can, of course, add that to a living will. And there are different forms like the 5 wishes that has more of that kind of information built in. And we'll talk about that in a few minutes. But some things to consider with a living will is life support, cardiopulmonary resuscitation, otherwise known as CPR, mechanical ventilation, artificial nutrition and hydration, like tube feeding. And again, in New York State, you have to put specific wishes about that in the living will in order for your agent to make those decisions. Kidney dialysis, surgical procedures, diagnostic studies, intravenous lines, antibiotics, blood transfusions, chemotherapy and radiation therapy, organ or tissue donation, right? Those can all be different components of living will and different types of treatments that you can think about. And here's some sample language of living wills, right? They can be sort of the checklists, I do or do not want to receive certain interventions. I do or do not want to be taken to a hospital. I do or do not want pain medications, cardiac resuscitation, mechanical respiration, blood or blood products, right? And so for people of certain faiths, they don't accept blood products. So that's very important to be able to name that and make sure that people know if there are certain things based on your faith or your culture that are important to you, that you are able to name that in your instructions and that your healthcare proxy knows. Dialysis, antibiotics, right? These are different choices that can be made. And again, we encourage people to think about the why behind this, and are there circumstances in which you would want this or not want this, right? Or I would want to try all of these things for a certain period of time to see if my condition got back to a certain baseline, right? And then if not, then I would want, my healthcare proxy to make other decisions to end those interventions or treatments. So there are some limitations, and Brian, when he comes on, is going to talk with us a little bit more about this. There are some limitations with the living wills. So living will goes into effect when an individual is unable to make decisions. They do not guide immediate medical care. So if the EMTs are called in during an emergency, they will do everything to sustain life. And the healthcare proxy cannot stop this using only a living will. So once in the hospital, the healthcare proxy can make decisions if a person is unable to do so. So we're going to talk a little bit about medical orders, right? And those are different than living wills. They do direct immediate care, unlike a living will. So we want to make sure that everybody knows that a living will does have some limitations. They're truly future planning documents that go into effect if someone is no longer able to make decisions after things have been done to, sort of get them into a hospital situation. And then medical orders, right? So you can see these planning forms at a glance. We talked about medical power of attorney. That's another term used for the healthcare proxy or healthcare agent, right? That's a legal document that establishes who you want to make decisions on your behalf. The living will is the sort of instructional document, right? And it should be used along with conversations, right? So a lot of times people will name someone as a healthcare proxy and not talk to them about what they want. So we hope that after today, you will have those conversations and be sure that if you are named as a healthcare proxy, that you are able to talk with someone to their ability to understand their wishes or start thinking about how you might make those decisions. And if you name someone, that you start those conversations. And so a medical order, and there are different types, which we'll talk about in the next couple of slides. A medical order are instructions given by a healthcare provider regarding care and treatment of a patient. So they are created along with a doctor or nurse practitioner. Medical orders can cover different treatments and interventions, and they direct current care. So medical orders can include a couple of different documents. One is a do not resuscitate order. There are do not resuscitate orders that can be in hospital or out of hospital. So sometimes if people go into a procedure, they'll be asked if they want to sign a do not resuscitate, right? An order specifying that if the heart stops, they don't want cardiopulmonary resuscitation. There are do not intubate orders specifying no breathing tubes. Again, they can be specific to a certain hospitalization or medical procedure. There can also be out of hospital DNRs and DNIs for in-home use. And Brian, we're looking forward to your perspective on this. What I've heard is that it's helpful to put these forms on the refrigerator or somewhere easy for EMTs and paramedics to find. So there is also a more comprehensive document in New York State. It's called a medical order for life-sustaining treatment. It's called different things in different states. In New York, it's a MOLST, medical order for life-sustaining treatment, also known as physician orders for life-sustaining treatment. In New York, it's on a hot pink paper. And it includes a section on goals of care. So it allows people to think about if they want full treatment, if they want selective measures or comfort care, right? And those are different sort of levels of treatment, and enables decisions about CPR, respiratory support, feeding tubes, antibiotics, and dialysis. It is, because it's completed with a doctor, it's a bit more binding than a standard living will, and it can protect people from medical interventions at home. And again, this can be displayed on the refrigerator. So if this is of interest, typically people consider completing a MOLST when they have a more advanced condition and they know that there are certain treatments they would want or not want, right? If they have strong preferences about treatments, like I'm full measures, I want I want everything to be done every step along the way. Most can be great to put that into writing with a doctor. Or I know that I'm selective measures. There are certain things I would accept under certain circumstances. You can put that into effect with the doctor as well. And healthcare proxies also can have these conversations. So for someone with more advanced dementia who is not able to make those determinations, a healthcare proxy can complete a MOLST. A named healthcare agent can complete a MOLST along with a doctor or nurse practitioner on their behalf. So some other considerations, again, continuing to emphasize starting the conversations, talking about wishes and what you would want or not want, ensuring the documents are signed and witnessed, right? So for the advance directive, which is both the healthcare proxy and the living will, different states have different standards for what completes that document or makes it a legally binding document. In New York State, you need 2 witnesses. So in some states, you need a notary public. In New York, you need 2 witnesses. Those witnesses cannot be someone named as your healthcare proxy. So a lot of times people might go to the bank, or if they're involved in different kinds of community groups, they might take it there and have people sign for them to witness their signature. Other considerations are, what you do with these documents. A lot of people think, because it has the word will in it, people think, oh, well, my final will and testament, right? My estate planning document about where I want my assets to go, that's in a safe. So I should put my living will in a safe too. No. You want your living will, you want your healthcare proxy and living will documents to be accessible in an emergency situation, right? So you want people to have copies of them. You want anyone that you named as a proxy or a backup to have a copy. You want your doctors to have copies. You want these to be easily accessible documents, right? You may keep a copy potentially in a purse or a wallet if that's important to you, but you want to guarantee easy access in a case of emergency. And you might consider when you want to update. Again, advanced care planning is a process over time. So if your life circumstances or healthcare status changes, you might want to consider updating, looking over your advanced directive document, see if it's reflective of your wishes. Changes in marital status. If something happens to your named healthcare proxy or your relationship shifts or changes, you would want to update that. Looking about every 10 years, every 5 to 10 years, reviewing, updating, making sure it's reflective of your current wishes. If you move to a new state, completing a document for that state is very helpful and beneficial. And if you experience the death of a loved one, again, updating your documentation at that time can be very beneficial. So we are about to have Brian come on. I am just going to look at some questions here.
Yes, and I think we did have 2 questions in the chat. Thank you, Pam, for all that good information. Monique is asking, where should the living will be kept? Who should have copies if family's unavailable? Which was touched on some, and so can reiterate or
Thank you for that question, Monique. It's a great one. I think you can keep it somewhere that is easy for you to access. Some healthcare systems actually upload advanced directives now. That's becoming more common. And I know that some states are working on registries for advanced directive documents. So you can, if there's family unavailable, you can talk with your doctors about, how do I ensure that this information is accessible to you, and give them copies. And whoever is named as a decision maker can have copies as well. And Brian, we would love your input on that too, on where to keep those. Um, who decides when the person is no longer able to make decisions on their own? In dementia, wife's diagnosis was provided in 2023, but in 2025, I thought she was unable to make a decision. Is that enough? Bob, it's a great question and a complex one. I think that is really determined by what the decision is, right? There's concepts in decision making of, can people understand the consequences? Can they understand the type of decision they're making? And can they really understand the consequences of that decision, right? If it's about a emergency procedure, or if it's about a surgery, do they understand a little bit about what that surgery is, what could be the benefits of that operation or procedure, what could be the consequences or the downsides of that, right? So it's kind of based on, someone's ability to understand things. Now, with dementia, we know that can be fluid, right? Some people might have understanding of certain things, less understanding of other things. So I think that's a great conversation to have with a doctor to, talk about. Obviously, if someone no longer has language, or if they're really not able to identify anyone in their family anymore or know who people are, those are usually signs that someone is no longer decisionally capable, because they're not able to know who they're naming to make decisions, or don't have that understanding anymore. So it can be a bit of a continuum, and it's a great question to talk about with doctors.
We have one more that just came in. As far as healthcare agent to appoint, any New York policies or advice on the agent being a paid caregiver, PCA or CD pass?
With so if the caregiver is a paid caregiver through a paid caregiving program like CD Pass, and is also a family member, I believe they are still able to be a decision maker named. I don't know if you have more insight on that, Brian, but if they are not a family member, it should not be a paid caregiver, right? So a paid caregiver, I can go back to the slides here. Right? So it says here, an employee of your healthcare provider, or a paid caregiver, a spouse or close relative accepted. So if it's someone who is a paid caregiver and a family member, I believe that they are still able to be a decision maker, but that's a great question. Those are newer programs. So thank you for that. Okay, thank you. Zuliani, I'm sorry if I'm not saying your name correctly.
No, you did. You did. Yeah, so that my understanding when I worked with home care agencies is they're very explicit, especially with CD Pass, to have the family appoint someone else to be the proxy. So if the person who, let's say, is already assigned a healthcare proxy wants to now be a paid caregiver, they usually have the conversation with the family about picking another proxy.
Okay, that's
I
great
think there are
information.
exceptions that have been made, but they usually like to see that at least other families involved in the decision making, and that, it's kind of nuanced in that way.
Yeah, thank you so much for sharing that.
Of course.
I think that's really important because, and the reason behind it, of course, is they don't want there to be a conflict of interest, right? That someone is a paid caregiver
Exactly.
and
Yeah.
also making
Yeah.
healthcare
Especially with
decisions. So
advocating for things like hours and kind of that thing that it gets complicated, it gets muddy.
yeah. Okay, great. That's great information. Thank you so much. So yes, so finding a different healthcare agent in those circumstances is helpful and important. Thank you.
All right. I
Okay,
think that was it in the chat for now.
great. And we're gonna turn it over to Brian now to
Great.
share some information. I'm gonna pull up the slide here to share information from a paramedic's perspective on planning.
Great. Thank you, Pam. I appreciate being able to speak to everybody. So I'll just give a brief overview of what EMS is. I'm sure some folks on this chat have called 911, had either gone in an ambulance themselves or with a loved one. So EMS started in the 70s to reduce out of hospital deaths from cardiac arrests and traumas. Today, EMS responds to, I think it's over 2 million calls in New York City every year. Um, when you call 911, you speak with the dispatcher first to elicit all the necessary information from you, what's going on, your location, things like that, to make sure you get the appropriate resources. You may get two EMTs, you may get two paramedics. We'll talk about the difference in a moment. You may get up to 7 or 8 people, including firefighters and police officers. So just something to be prepared with, that you may have 5, 6, 7, 8 people standing in your home in the next few minutes. And then almost all calls in New York City result in a lights and sirens response. So you'll usually hear folks coming as well. The next slide, please. Thank you. Okay, so who's treating you? EMTs versus paramedics, what's the difference? So EMTs provide basic life support, oxygen, CPR, bleeding control, some oral medications. Paramedic and the EMT schooling is about anywhere from 4 to 6 months. Paramedics are EMTs who then have an additional year of advanced training. They can do IVs, EKGs, advanced medications, advanced airway maneuvers like intubations, things like that. Depending on the nature of the call is who gets dispatched. So when you're telling the dispatcher what's going on, they have an algorithm to decide what resources and who would be most appropriate for that particular emergency. If for whatever reason EMTs come and they feel like they need paramedics, they can always call for paramedics. Both EMTs and paramedics follow standing medical protocols, and then also have the ability to conference in a licensed physician as well, if they need additional guidance or just want to talk something through. Perfect. Okay, so what to expect when the ambulance arrives, and what to expect when you call 911. So like we said, when you call 911, dispatcher will ask you a number of questions. It may seem like you're on the phone for a long time. It may seem repetitive, but they're really trying to elicit as much information as they can to make sure the appropriate resources get to you. Also, while they are asking you questions, ambulances have already been dispatched to the area and they're just providing the crews updates as they're coming in. They may give you instructions on what to do, perhaps talk you through how to do CPR if the person's not breathing, doesn't have a pulse. They can also talk you through how to do bleeding control as well. So really important to listen to their instructions, and they'll really talk you through what they need done. They may ask, the events that, excuse me. So once the ambulance arrives, the providers will come out and will start getting medical history, start a physical exam, or start treatments depending on what's going on. So the questions will include, what's going on, what happened, what caused this injury or illness, what sort of medical problems does the patient have? Do they have allergies? Do they have medications that they take daily? Did they eat recently? What other medical history is really pertinent? The physical exam will be tailored to depending on what is going on. If it's some sort of cardiac cause, patient might get an EKG done. Certainly, the paramedics will listen to their heart and their lungs, maybe do an abdominal exam or a neurological exam if one of those is a concern. And then they'll kind of gather everything up, take the patient down into the ambulance, and then take them off to the hospital. Now, hospital destination in New York City in particular is pretty limited in terms of geographical location. So most often the ambulance will be going to the closest hospital. Now, I know that can be a little distressing to some folks who maybe go to a different hospital that's not the closest to where they are. But unfortunately, that is kind of a policy that New York City has. Um, there are some exceptions to that. If the case warrants or the patient warrants specialty care that the closest hospital does not have, then they'll proceed on to the closest appropriate destination. There are very few maybe exemptions where you can go to a different hospital, but those are usually very limited. And I think it's important to kind of understand that you'll probably be taken to the closest hospital. Okay, sorry. Next. So how can we prepare? So you've called 911, you've given all the information, great. Clear path for first responders when they come in, if you're able to do so, make sure that they can open the door. They'll be coming in with probably 50 to 60 pounds of equipment, plus either a stretcher or a foldable wheelchair, something like that. So the easiest kind of pathway to the patient is ideal. If you can meet us at the door, that's great. Keep the door unlocked or open. If you live in a doorman building or have a security guard downstairs, let them know to expect the ambulance to come through. Sometimes certain older buildings may have back entrances that have ramps or that are larger service elevators. If that's something that would be helpful, you can have either a super or somebody kind of lead us around. That'd be really helpful as well. If you have pets, we love dogs, but it's great if you can kind of lock them up into a room with 2 to 7 or 8 people showing up. Dogs can get and other animals too can get a little nervous. So if you can kind of just lock them in a separate room while we're conducting our business, that'd be outstanding. Having an updated list of medication, allergies, conditions. Pam had mentioned this before, and we'll talk about this, kind of combine this with the DNR, the MOLS forms, easily accessible. Some folks will have like a full packet of their medications, their allergies, their medical conditions, maybe even their PCP's number, and their DNR or MOLS form or whatever else they have, kind of all stapled together and either plastered onto the fridge or above the bed, someplace easily accessible and easily noticeable if it's just the paramedics in the house and there's no additional person. Folks also if you can, keep an updated list of medications and allergies in your wallet. So if you're not at the house, you can kind of grab that out and hand that to the paramedics as well. You can also set up your medical ID on your cell phone as well. I certainly, look for that if the patient is kind of unable to talk to us. That's something that I'll look into there. But it's also just an easy place if you don't carry your wallet with you at all times. Most people carry their cell phone pretty regularly. Having your insurance card too, it's just one of those things that can kind of help cut down the paperwork that you get afterwards. the paramedics can just enter it in. And that way you can avoid, getting bills initially. And then I think just in general, understanding that while the paramedics may seem very direct, they're they want to, they're working with kind of the utmost speed to try and make sure that they are performing the appropriate exam, giving the appropriate treatment, and then getting that patient over to the hospital as quickly as possible. And I believe that is all I have.
Thank you so much, Brian. That's
Problem.
so helpful, and we encourage questions for Brian as well. I'm gonna finish up just a couple more slides to finish up, and then we'll get to the questions. So again, kind of in summary of what we've been talking about today, in really the advanced care planning process involves these different components of really thinking through what your wishes are, who can make decisions, what that really looks like for you. Having those conversations, discussing your thoughts with the people that you trust around you and your healthcare providers, and recording your wishes, sharing your plan with people you trust, right? So sharing your plan, not keeping it to yourself, but sharing it with loved ones, healthcare providers, family members, right? Not just sharing it with the person you've named to be the decision maker, but also other members of the family. So they know what to expect, and they know, if you want other family members to support the person that you've named as your decision maker, let them know that, and let them know what decisions that you've made, right? So having those conversations can be so, so helpful. And then we have some references and resources that are a part of the PDF that Rochelle put in the chat. So you should be able to access that. We're also going to send an email afterwards and include the PDF as well. So the National Institute on Aging has some information about advanced care planning that can be very helpful. New York State Department of Health and the New York State Advanced Directive page is very comprehensive. They have a lot of great information on there. They have the forms to fill out, both the healthcare proxy and the living will. So those are really fantastic resources. There's also a document called the 5 Wishes. It's a type of advanced directive. It's in very plain language and allows for a lot of personalization. It's valid in 46 states, including New York. And it gets into the interventions that we talked about today, but also some of those care preferences. How would you want to be cared for? Is there music that you would want around you, or certain other things, right? So it gets into those more nuanced choices as well, and can be just a good, whether you want to use it formally or not, it can be a great discussion, a great thing to discuss. Conversation Project is also a great resource. They have free guides for starting healthcare planning conversations. Similar to what I showed you from Australia, they have prompts and ideas for how to start conversations. These conversations can be really difficult to start. Not everybody wants to talk about this, and not everyone's comfortable talking about it. So sometimes even starting, by saying something like, I went to a webinar today about advanced care planning, and I realized that we really haven't talked about this. What are your thoughts about having this kind of conversation? This is why it's important for me to have this conversation, and I'd love to do that. Can we revisit this in another week or so? You can think about it a little bit more, and I'd like to just, start talking about some wishes together. That can be sort of a gentle way in. A lot of people think that they want to have one conversation and be done with it. But sometimes it's best to do it over multiple conversations, smaller conversations that allow you to get into those kinds of those conversations more. So thank you all. We're going to turn to some questions now.
Yes. Thank you, Pam and Brian, so much. And I also vouch for the 5 wishes document. It's so great just to, again, get those conversations started. Having a physical booklet is just kind of helps in leading the process forward. And so we have a question in the chat from Joyce. What is the eMost?
That is an electronic version of the MOLST form. And that I do believe that's available in New York State.
Mm-hmm.
Yeah, that one is it. Sorry, I just want to reiterate, I think I might have glossed over it. Pre-hospitally, and Pam had mentioned it as well, pre-hospitally, just the MOLST, eMOLST, and the out-of-hospital DNR are the only 3 valid documents. Living wills, unfortunately, are not valid out of hospital. So even if you have a living will saying you don't want CPR, your loved one doesn't want CPR, has specific medical requests, unfortunately, that's not valid. So I certainly encourage everyone to have either the out of hospital DNR or the MOLST form available for out of hospital emergencies.
Right. If you know that that's the intervention you want now, right? Like first, for some people, if that's not what you would want in an emergency situation, then you don't need the most for that. But if that's what you know you want, the medical order is the way to ensure it. Thank you for reiterating that, Brian. So important. I think a lot of people don't understand that nuance.
Yeah.
And it's really important to understand what these documents are and what they can and can't do so you can make the decision for yourself about what is right for you, because advanced care planning is one of the most personal things anyone will ever do, right? It's extremely individual. What you want, what you don't want, right? There's not a right or wrong. It's really based on your wishes and preferences. And we hope to provide this information so you can start conversations with your doctors and your loved ones so you can ensure that you have the right things for you based on your wishes and preferences.
And following up on that, I think goes, how do we access this pink form for the print version of the MOLST?
That would be in conversation with your doctor. You would want to talk to your doctor because it is a medical order. The living will is a document of an instructional document, but not a medical order. This is a medical order that gets filled out and signed by your doctor. So you would get it you can talk to your doctor about the most.
Thank you. And then we have another question in the chat. What services can you call to be transported to a hospital of choice?
Yeah, some hospitals have ambulances that are outside of the 911 system that you can call to get transported to that particular hospital. Some of them also contract with private ambulance companies to transport patients to their hospital system. I will say though, even in those cases, if a patient is, severely unstable, it's likely that they'll still divert to the closest appropriate hospital. But as I said, depending on where you get your healthcare, they often have either a contracted service or their own internal ambulances that can be called.
Thanks so much, Brian. Do you encourage people to have those conversations with their healthcare systems if that's important to them?
Yeah, if it's important for you to, all your doctors are at Northwell, I certainly would encourage you to kind of speak with them about, finding, getting access to their ambulance number. I think a couple others. New York Presbyterian, I believe, has one. I think NYU is starting one. So the systems are the big healthcare systems are starting to put those together. But again, I certainly encourage you to speak with the healthcare systems.
Great. Thank you. Thank you.
And it looks like there was one other mention in the chat for just request of attendance for this. I don't know, Pam.
Sure, I can put my email in the chat. Typically, we have professional development opportunities where we provide certificates of attendance. So this is one of our family offerings. So that's not common for these, but I can put my email in the chat and you can reach out to me.
Any other questions from our participants today? These have all been great. And I will also reiterate the links that are important to check out for future educational seminars, our social engagement calendar, see what's going on. Along with our helpline, we have a dementia navigator on Monday through Friday, 9 to 5 to help with any outstanding questions. And anything else from Pam or Brian today?
Thank you so much for joining us, Brian. It's so helpful to hear from your perspective and your experience. I think a lot of people aren't sure of what it looks like when 911 is called or what you can do to be prepared. A lot of people ask about, that idea of something happens on the street.
Yeah.
What documents should I have on me? So knowing about, that you can set something up on your phone or carry things in a purse or a wallet, that it sounds like EMTs are trying to do everything they can to care for the person in the best way. And if there's guidance on how to do that, they want to use that. Is that?
Absolutely. Yeah. I think, our priority is the patient, and, whatever we can do to give the patient the best possible care, we want to do. So, and the more guidance we have, the more information we have, the better care we can provide.
Excellent.
And yeah, it's real quick. It reminds me of something that I talked about in a group recently, and they asked about if the ambulance is to be called on their person, or they need it because of uncooperative behavior or unstable. There is like an Article 9 area in writing that it's if they're exhibiting these behaviors, they can be involuntarily admitted for evaluation. Is that something that is there a way to prevent that, or do you know anything about that to help just kind of calm the nerves if that is to be a rule?
Yeah, so my understanding is for somebody to be voluntarily or involuntarily held, there needs to be a two-physician agreement.
Mm,
So the patient may be brought to the hospital, but and again, I'm not 100% sure, but I'm pretty sure that it requires at least a two-physician, it's called 2PC, a two-physician, like two providers to agree that this patient could be a danger to themselves. But either way, a patient will be evaluated by at least one, if not two physicians once they arrive in the hospital, to determine, what is the actual cause of, is it a true psychosis, or is there an underlying medical issue going on? Is it agitation, secondary to dementia? So I think that, just reminding folks that, the patient, even if the patient is brought to the hospital, they'll still be evaluated by a physician to determine whether or not they need to be held as a result of their for their own safety. And I think a lot of physicians don't take that lightly. So.
Thank you. Thank you, Brian. This is also making me think of, if you are a care partner for someone living with dementia, you might want to write that in your emergency documentation as well.
Absolutely.
So if something happens to you, the EMTs will know that there's someone living with dementia that depends on you, and they can try to make sure that person's safe, whether they're with you, or not. They can make sure, either bring that person to the hospital with you if they're there. Any other thoughts or ideas about that situation, Brian?
Yeah, I think certainly we're not going to leave anybody in an unsafe situation. Whether or not, if the person is, unable to ambulate, and there's no available caregiver to come and either relieve the person who's going to the hospital or what have you. I think kind of the worst case scenario would be the person would also be transported to the hospital just to provide a safer location for them. But I think most effort will be kind of undertaken by both EMS on scene and then police as well to find either a better alternative than also taking that person to the hospital, whether it is, getting in contact with an alternative caregiver is usually, I think, the kind of big one that we go to. Um, and if you have that information available too, that could be also something that would be important to kind of put up somewhere, I'm unavailable, please, emergency contact, whoever. Um, and so I think that's useful information as well.
Great. Thank you so much. Yes. So if you are a care partner to someone living with dementia, be sure that in your emergency contacts or in your information that you note that and back up people who can be called to help keep that person safe as well. Thank you all for being here today. Thank you for the great questions and interactions. It's really great to learn from each other. And Zulani, thank you for chiming in there. Really appreciate you all being here today and being a part of our CaringKind community.
Yes. Keep a lookout on our calendar for the next opportunities. I think on Monday we have a legal and financial aid seminar that we can follow up. It has some great information, and then we have a musical a music intervention connection seminar coming up in August as well. So hope to see you guys there and have a great rest of your day.
Thank you all. Thanks again, Brian. So glad you're here today.
No problem. Thank you so much for inviting me.
Thank you, everyone.